All right, let's dive right in. Today, we're going to talk about observational research, especially for those of you on the front lines in anesthesiology, critical care, and pain medicine. We're going to take the incredible wisdom from Professor Rakesh Garg's research pearls and boil it all down into a super practical guide for your next study.
And look, this isn't going to be some dry academic lecture. We are breaking down complex principles into real, actionable steps you can actually use. Think of this as your blueprint for turning those fascinating clinical observations you make every day into some seriously high-impact research.
So, here's our roadmap. We're going to follow the logical flow of a research project. We'll kick things off with how to craft the perfect question. Then, we'll get into the nitty-gritty of bias, what it is, and how to avoid it. From there, we'll talk about collecting solid data, analyzing it the right way, and finally, sharing your findings with integrity. Let's start at the very beginning. Because every single study that changes how we practice medicine, it doesn't start in a fancy lab. It starts with one thing, a clear, focused question that comes directly from a real clinical problem.
Now, a question like this probably looks familiar, right? We've all started here. It's a great thought, born out of genuine curiosity at the bedside. But here's the catch. A question this vague is almost guaranteed to lead to a vague, inconclusive study.
So, how do we get from that fuzzy idea to a laser-focused target? Well, we use this awesome tool called the PICO framework. It forces us to get specific. P is for population. Who exactly are we studying? E is for exposure. What's the intervention? C is for comparator. What are we comparing it against? And O is for outcome. What are we actually measuring? See how that transforms the question? It goes from a vague thought to a precise testable hypothesis. That right there is the foundation of a great study.
And once you have that sharp question, it's like a compass. It points you directly to the right study design. If you're asking a what will happen question by following a group forward in time, you're looking at a cohort study. If you're starting with an outcome and looking backward to find a cause, that's a case control study. And if you just want a snapshot of what's happening at one single point in time, well, that's a cross-sectional study. The question itself tells you what to do.
Okay, so you've got a clear question and the right design, you're on your way. But now we've got to talk about the single biggest challenge in observational research, the hidden minefield of bias. Spotting these traps is what separates a truly credible study from one that's just plain misleading.
The confounder. This is the big one, folks. Think of it as a hidden third wheel that messes everything up. It creates an illusion, making it look like two things are connected when they're really not. If you don't account for it, your entire conclusion could be built on a house of cards. Here is a perfect real-world example. So you notice that patients on vasopressors have a higher mortality rate. The immediate thought is, the drug is harmful. But wait, who gets vasopressors? The sickest patients. So is it the drug causing the outcome, or is it the underlying severity of illness? That severity of illness, that's your confounder.
Next up, let's talk about who you're actually studying. Selection bias sneaks in when your study group is kinda off, when they don't really represent the larger patient population you're hoping to understand. It means your findings might be true for your specific little group, but they might not apply to anyone else in the real world.
This is such a classic example of how that works. Imagine you're studying post-op complications, but you only enroll stable, elective surgery patients. Of course your complication rate is going to look amazing, but you've ignored all the high-risk emergency cases, which means your results paint a totally unrealistic, rosy picture of what's actually happening. So, how in the world do we fight back against these biases? Well, the answer isn't some fancy statistical trick at the very end. Nope, the real defense starts way earlier. It starts with rigorous, super careful, standardized data collection. That is the bedrock of any study you can trust.
You know, one of the best ways to keep your data solid is to use tools that are already validated and standardized. Instead of just writing patient is sedated, use the RASS score. Instead of seems confused, use the CAM ICU. For pain, use a visual analog scale. Using these tools makes your measurements reliable, consistent, and, crucially, comparable to other research out there. And this idea of precision applies to literally everything you measure. Don't be vague. Don't just jot down opioid use. Define it. Was it fentanyl, morphine? What was the exact dose? For how long? It's these crystal clear definitions that make your work reproducible, which is the whole point of science, right? Okay, so you've framed a brilliant question, you've sidestepped the bias traps, and you've built this beautiful fortress of high-quality data. Now for the fun part.
turning all that raw information into actual, meaningful insight.
The analysis itself really isn't as scary as it sounds. You can think of it as a logical 3-step path. First, you just describe your patients. Who are they? Second, you compare your groups at baseline to see if they were different from the get-go. And third, and this is the magic step, you use statistical tools like multivariable regression to mathematically adjust for those pesky confounders like age or illness severity so you can isolate the true relationship you care about.
Now, here's another really cool technique in your toolbox, propensity score matching. In simple terms, this is a statistical trick that lets you take your messy, real-world data and create two groups that are almost perfectly balanced. It's kind of like creating a mini randomized trial out of observational data. It's incredibly useful for dealing with that confounding by indication problem, where sicker patients get a certain drug, making the drug look bad.
We are in the home stretch. This is the final, and you could argue the most important stage of the whole journey. You have your results. Now, how do you interpret them correctly and share them with the world in a responsible way?
Okay, listen up. If you remember only one single thing from this entire explainer, please let it be this. Observational studies are amazing for finding clues and potential links. They show us associations, but they cannot, by themselves, prove that one thing causes another. It's so important to be humble in your conclusions.
And to make sure we're being as honest and clear as possible, we have guidelines like the STROBE statement. That stands for Strengthening the Reporting of Observational Studies in Epidemiology. Just think of it as a checklist. It ensures you report everything you did with total transparency so that your peers can really understand, critique, and hopefully build on your amazing work.
Which brings us right back to the beginning. It all starts with you in your daily practice. The patterns you see, the questions that pop into your head at the bedside, those are the seeds of the next big breakthrough. Observational research is what uncovers the questions that launch those huge clinical trials. It all starts with one small step, asking one clear question. So what's yours going to be?